You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 18th, 2025. We will be doing our orientation series, and our topic today is Rhinitis. This is presented by Dr. Chris Miller. He is an assistant professor of pediatrics and is the fellowship program director of allergy and immunology at Children's Mercy Hospital in Kansas City, Missouri.
Today. The clinical diagnosis of this is the diagnosis of rhinitis is suggested by the presence of one or more of the following, and that's nasal congestion, rhinorrhea, which would be anterior versus posterior, sneezing, and itching. So you just need to have one of those to be called rhinitis, right? Dr. Portnoy has suggested renaming it for other reasons we'll get into. His favorite, I believe, was the nasal dysfunction syndrome, or NDS. I kind of like that one. And then the kind of a fun term was the SNF, which is syndrome of nasal ill function. Now, we're still going to be calling it rhinitis with some modifiers on it. Why? Because ICD-10 doesn't recognize our fun terms here of NDS or SNF. Anyway, if the patient has bothersome nasal symptoms, then by definition they have nasal dysfunction. And then our job is to try to figure out why do they have that. About it. It does affect quality of life. I'm not going to get deep into the studies and the numbers here, but sleep disturbance is a big factor for these folks here. They can also have presenteeism. That's where they go to work, but they can't on the work because they're too busy functioning on their or paying attention to the nasal symptoms here. And then absenteeism would be, I can't go to work because I'm too sick and I stay home. My sinus pressure is killing me. So we have decreased work production. And then certainly can affect comorbidities. As we know, people with kind of eosinophilic driven asthma, about 8 out of 10 have an allergic component. So it can affect their other comorbidities too. By numbers, 10 to 30% of adults report allergies. The numbers have a range here because if you go to a party, they find out you're an allergist, everybody talks to you about their allergies. In your head, you're going, it's not all allergic, but they might have rhinitis, so it's a common problem. And then children have a very heavy load of the allergic rhinitis, up to 40%. And the info I found on non-allergic was about 7% of the U.S. population, 350 million plus people. That's a big number. So it affects a lot of people. A little bit the physiology of the nose. What does the nose do other than produce mucus? It's an air conditioner for the lower airways. It humidifies and warms the air that you breathe. It filters out ripples. It's important in olfaction and phonation. It's a source of nitric oxide. So it's got multiple purposes. If you don't think you need your nose, plug your nose and walk up the stairs, and you'll see how well it doesn't go. You're out of breath, and it's pretty miserable. And then just like when you have a cold. So. All right, we're going to dive into a case presentation, and then we're going to step away from that and talk about everything else. We work in pediatrics, obviously, so you're going to hear a lot of this, and you'll recognize, maybe the second years will recognize a lot of the answers that are kind of meant to be a little bit silly. But a mother brings her 4-year-old in because he has constant nasal symptoms, and she wants to know what allergies are causing them. So that's the presumption, is it's allergic up front. They were told it's allergies. They've probably been treated with allergy meds at home. When you ask him about the child's symptoms, she tells you that he takes an allergy liquid once a day. Doesn't recall which one. That's not uncommon. Tried a nasal spray, but he won't use it. Now, the question you asked was about the symptoms, but she went right to the medications, right? And that's a common thing we see. Upon further questioning, you discover that he has some nasal congestion and some drainage. When asked if he has ocular itching, drainage, or injection, the mother turns to the 4-year-old and says, "Do you?" And the 4-year-old looks back at mom, and then he rubs his eyes. So, not uncommon. And then when you ask about, is this episodic, seasonal, year-round, I'm trying to get a duration, how severe and how affected he is, she's not able to answer the question. 2 minutes of time goes by and you still don't have an answer to it. So From this, what can you say about the child's nasal dysfunction? And again, this is Jay's term, so I'll give him credit on that. All right, now I'm going to step away. So many of the things you already know here. I'm just trying to be complete and throw some caveats on here. History is terribly important. History. Nasal symptoms is where the money is, but you're going to have some associative symptoms, so I included those. If you say congestion, you make it a blank depending what age group you're asking here. They may be stuffy, maybe their term, or blocked up. It's what you hear on congestion. If you mention rhinorrhea, they'll give you that funny look also, and drainage, snot, and mucus are probably other terms for that. Sneezing is pretty obvious, itching. Postnasal drainage here, not everybody will kind of report that, but if you ask, do they clear their throat a lot? That sort of thing constantly. Then that might be a sign that they have some nasal drainage going on. The end is if you have a lot of PNV, then you may have a cough that's persistent. So when we're looking at somebody for asthma, but they've never wheezed, now albuterol didn't work, and they've never gone to ER, and they've got this cough, maybe it's all upper airway cough, could be related to postnasal drainage. Sinus pressure and pain, and when you get to sinus involvement, that may be a reflection of just the nasal obstruction. On the other hand, it may be an inflammatory component in the sinuses, so like a rhinosinusitis, just to modify the definition a little bit. And then asking about snoring is important with that. Does everybody snore? Yes, probably everybody snores. It's kind of, you're asking about impairment with snoring. So like restless sleep or daytime somnolence would be something to ask about here. And then the associated ocular symptoms, periocular swelling. It's not eye swelling. I'll change it in your note if you leave it in there too. If their eye globe is swollen, you get them to an ophthalmologist right away, right? It's periocular, it's the swelling around the eyes. Parents is the other term, that's fine. Watery drainage, and typically for allergies, there's no reason just one eye to be having an allergic reaction. You could maybe argue, sensitive, you pet the cat, you rubbed your one eye only, didn't go to the other eye, and maybe unilateral, but in general, it's going to be bilateral. And then itching and injection are pretty common things you'll want to ask about. Do they get red and itchy? As far as ear symptoms here, I do a question mark because I don't know how much the ear symptoms fit in, and we don't target that a lot. But you'll hear people complain about my ears feel full. If you take a look at them, you'll see the kid with the finger in their ears digging like crazy, and I don't have any hard data on that one, but I'll throw that into the picture. You ask about duration, seasonal, spring and fall is the answer you'll get the majority of the time, or year-round. So they could have seasonal, they could have year-round, they could have year-round with seasonal worsening, and then they could have episodic. And episodic might be two households, like go to dad's house, there's tobacco smoke and a cat there. Okay. And then they go over there, they're sick for a few days when they come back to the other household, so it's just episodic and goes away in a week or whatever. But you also need to differentiate that from upper respiratory infection. Remember, URIs are common here. We're probably looking 6 to 12 on the younger kids per year. They last 1 to 2 weeks with a little bit of post-recovery after that. So they look like they're sick about half the time. So a lot of times we're chasing is just URIs there. Do you need to identify potential triggers? Animals, pollens are your trees, grasses, and weeds. Molds, mites, cockroach, mouse. Those are all kind of on the allergic rhinitis side. The others that you want to ask about is foods. There may be kind of a gustatory rhinitis, spicy foods. Could be activity. A lot of people who are doing sports, running around the track and stuff will start sneezing and blowing and snot and all. Stress can certainly do it. Odors. Think about candles and fragrances and all that we kind of put odors in everything these days. Weather changes. I was kind of not a big believer about it, but I kind of think I am these days. And as I get old, arthritic, and I go, it's going to rain. My knees are killing me. I don't know. Maybe I'm still crazy on that end, but for the most part, I think there is a component to that with rhinitis symptoms. All right. Environmental history is important. You want to know they live in a house, apartment, other shared housing. Kind of age, the older the home, the more likely problems are. If you can't keep up with putting dirt around the house and getting water away, you might have more chance of a flooded basement if you didn't replace your roof, etc. The pictures you see on the right, we have a home environmental group we do consultations with. They'll go out and go to the house. There's a lot of caveats on what they can do or can't do, but they do assessments. I've gone out with them and I've been in homes that look like what we're seeing here on the right. You think, no, nobody was there. That's an old dilapidated, nobody was. Water leakage and high humidity is a perfect breeding ground for mold, and so these are the things you see. I put the picture in the lower right here. Those are mushrooms growing out of the plaster wall in a house. And I have a patient I've seen who said, "Oh, I got a mushroom growing on my wall." I'm like, "Really? You got a picture?" I saw a mushroom, but it was the same idea. And what that is typically that's a wall that is below ground. Okay, so it's underground, and there's probably one, in this case, plaster wall. I think the other one was plaster. Now I think about it, I don't think it was regular wallboard. But anyway, that's kind of what you can see. You want to know about pets, and don't just think cats and dogs. It can be also you have people with lots of birds that may live in there. The furry little hamster, rodent type thing. Some mice too. And you want to know about carpets, because carpets are nice collecting pits for all things allergic and dirt and dust. You want to know about exposures, tobacco, other smoke, and then certain odors. So you have this little plug-in room deodorizers in every room. Stuffed animals would be important because they harbor mites, and then infestations. So shared housing, very high risk of mouse and roach allergen numbers here. Been looked at study after study. So those are all important things to ask about. What you can do about it, and will they do anything about it, is a different thing, but we'll stay out of that right now. You want to know their medication history. I broke down to oral, nasal, and ocular. Fairly complete. There may be a few other categories I didn't throw in there, but antihistamines and leukotriene modifiers are your typical oral ones. Nasal medicines, we got lots of choices: steroids, antihistamines, anticholinergics, cromolyn, and saline. And most of the antihistamines that are out there are also mast cell stabilizers, so I throw that in there. And then steroids, although I personally don't do steroids for eyes, I give them to the eye doc for that component, usually a good exam and long-term monitoring. That's there. And then I throw in biologics, although not currently for allergic rhinitis here. We are using those medicines in allergic asthma or atopic dermatitis. And there's some data to suggest the biologics can be helpful with the allergic rhinitis here. This is omalizumab would probably be when it gets more attention at that point. You don't prescribe it for that reason. It's not approved for that reason, but I can also put it in there. Okay. And then you want to inquire about surgical history, tonsillectomy and adenoidectomy. I put recurrence in there because remember when they do surgery, these are gross dissections. They don't pull out every cellular level here. And so I see probably about 5 a year at the Northland that have recurrence of their adenoids. They come back and it's the phonation's all nasal tone, and they say snot's all stuck on the back, and they're coughing and clearing their throat. And sometimes if I find out they're not allergic meds aren't helping, I'll reach further back to ENT. And I've had several each year that go back for revision of their adenoids. They could have subtle deviation and could have had a repair on that. I didn't put it in here, but a turbinate reduction can be done on patients with large turbinates. And then FES is endoscopic sinus surgery. I believe that's it's definitely with the scope, and I think it's a variety of things they may do, but it's a category at least, and you want to know if they've had that. So we inquire about their ENT visits. And on physical exam, these are typical symptoms you'll see for the nose and eye. We've got the bulgy, pale mucosa. That's kind of key. Edematous could be, if it's red, it doesn't make me want to think it's an allergy. Let me know I have bulgy some other time. That visit here, if it's more red, you're more of an irritation or an infection there. Drainage here probably doesn't matter. Clear is typical here. Cloudy white does exist. You could identify if they had eosinophils or not. That's not a routine practice anymore, but in the I'll say the old days it was. And then mixed rhinitis is the kind of third major category. Now, there's a whole list, and you can go many different charts about looking at other causes of rhinitis. These are important to notice. They're fortunately mostly rare. Okay, they're usually not coming to us. They probably have gone elsewhere and have other serious problems to get some of these diagnoses. but we still need to think about them. So if somebody's on CPAP, blowing air through your nose 24/7 is going to induce some inflammation. Okay. And it's not uncommon that they're going to feel congested from that here. They may put a humidity circuit on there to get some moisture in that. They may have a lot of itching because they're dry and cracked inside there too. Your occupational rhinitis is just exposure to other things that are irritants or allergens. Your rhinitis medicamentosa nasal decongestant spray is your number one. Is going to be name brand Afrin, generic oxymetazoline. You'll find people who've been on those, and they started out twice daily, and then they went 3 times, 4, 5, 6, 7, and all. I had a nurse that worked for me many years ago when I was in a different location. And for those of you who remember Skull chewing tobacco, you used to have a Skull ring in the back of your jean pocket because it pushed on it and caused a little circle. She had an Afrin bottle on her front pocket because she stored it there and ran with it daily. And so it does exist. I see probably 2 or 3 a year that I find that I'm able to wean them either with nasal steroids and occasionally oral steroid course, but it's out there. And then certainly in the older population, you got to think about intranasal cocaine. Systemic medication-induced rhinitis, and you'll see the list there. The antihypertensives probably the most attention just because they're commonly used, but that can certainly cause some problems. And the antidepressants are others, but you can't forget about oral contraceptives, the ED drugs, the aspirins, and some benzodiazepines. Then there's rhinitis pregnancy here. We will have a talk later in COLA by a good physician to talk to us about pregnancy associated allergic disorders. Atrophic rhinitis or empty nasal syndrome. And then some other diseases that can be associated with here. Hypothyroidism, probably the more common. You can see several other things there too. I don't think it showed up here. This is from up to date, but don't forget about tumors. They do occur. I have seen one kid with recurrent ear infections on the right side, resistant to treatment, got admitted, and he was new to me, and I noticed a little facial asymmetry on him, and I like, it looks like his right side nose was a little bit bigger than the left side, and I asked for pictures. The family pulled them out. He was symmetric before, and I said, "Do you see a difference?" Yes, he did. EMT scan nasopharyngeal tumor. Okay, so do think about other things that do that. His main complaint is the ear, not the rhinitis, but things like that do happen. Your differential diagnosis here, things that cause obstruction, foreign body, pediatric medicine, hair beads and marbles and little toys are kind of the common things that we see in those, and sometimes the ears. Don't forget about turbinate hypertrophy. You'll see people with 90% occlusion because their turbs are big. Adenoid hypertrophy, nasal tone speech might be it. A lot of postnasal drainage here. Some of those folks don't drain forward because they're so obstructed with their adenoids taking over the back of the nose and the airway, and they may be more gummed up and coughing and draining in the back there. Septal deviation, get a good look, and then polyps can be there too. Reflux complicates all this. So you take stomach contents and you reflux significantly up in your nasal passages. I bet you're going to cough, you gag, and develop inflammation if it's frequent. CF leak can occur, so somebody's had recent trauma. Tumor I just mentioned. All right, so where to get help? At the very bottom, allergyparameters.org. You guys know this well because we've talked about it, but allergy practice parameters, it's a combined joint task force, JTF, PP practice parameters, from the American Academy and the American College. They've come together and they created this here. And many of our speakers in the past and coming up here are the people who helped publish this. Our good Jay Portnoy's on there, former Chitra Dinakar. Has contributed to this through the years. And when you go to the webpage, parameters and guidelines, upper middle section there, click on that, you'll find the topic. You'll find old versions all the way to more recent updates. For our topic today, rhinitis, 2020 is the last update on that. These things are huge. There's lots of pages, looks like 46 pages if I'm doing my math right, on this here. Lots of wonderful charts and all that to look at. I can't summarize it. I'm going to show you lots of references to it, but I can't summarize it. And Dr. Mark Dykowitz will help speak on this a little bit later this year. Currently, they have 37 recommendations in the practice parameter. I don't expect you to look at those or read those. 5 of them relate to diagnosis and 30 are related to treatment. And just because everything we see typically starts US, just realize on over the pond, there's a lot of recommendations and groups that come up with parameters over there, and ARIA is one of them. They have a new one coming out, I want to say this year, but it's kind of the European version of what we do here. The ARIA stands for allergic rhinitis and its impact on asthma, so it's more allergic component, but it's something important to us allergists. All right, so why make a diagnosis? One, got to give the condition a name. Patients want to have a name. Why do I have this? They want the underlying trigger to find a cause and how to fix it. If you want to get paid, you got to have a diagnosis. Everything relates back to billing and coding. If you can categorize it, then it helps you figure out what treatments might be the best here. So if you have allergic rhinitis, we know about throwing avoidance medications in immunotherapy. If it's not an allergic rhinitis, then there still may be avoidance and triggers. So let's say your trigger is odors, tobacco smoke, avoid that, right? Medication still can help on those. And then if you have turf hypertrophy or polyps, then possible surgical intervention. Back to Jay's nasal dysfunction syndrome. This is information taken from the practice parameters, and it kind of is a little, the left chart is symptom driven to kind of suggest, what do you see in allergic rhinitis versus non-allergic versus infection versus chronic rhinosinusitis with or without polyps, and you can kind of go in there and fit the pattern on that. And then upper right is just a long list, a little bit more expanded than my prior list on the allergic versus non-allergic rhinitis diagnoses. Skip on that. And Jay went back and kind of divided it into categories. He said, well, we can treat allergen avoidance interventions for allergic rhinitis. You could maybe argue a little bit for non-allergic. You can be treated medically for allergic rhinitis and non-allergic rhinitis for upper respiratory infections or chronic rhinosinusitis without polyps. And then you can potentially get a procedure or an operation for other things like the sinusitis with polyps, septal deviation, turf hypertrophy, big adenoids, foreign body tumors, CSF. So he's kind of saying, here's the treatments that fit for which category. And then, nothing really works. Ciliary dyskinesia, although some concern about consideration for gene therapy. And then empty nose syndrome. These are the folks that have had significant sinus surgery. They're the ones who've been in multiple times and had things just opened up like crazy. And that was a pretty common pathway in the past. I'm hoping they do less of that now. They end up developing what the other term is atrophic rhinitis. And there's not a lot that helps them other than frequent ENT visits, sometimes a little bit of saline and lots of crust removal from the nose. But that's that ENT monthly to get that stuff done. Making the diagnosis. Guidelines recommend the clinician, number one, complete a detailed history and physical. We just went through examples of what to look for. Number two, review all current medications to see if there's a drug-induced component. Number three, use a validated instrument, maybe a scoring system, scale, or questionnaire to help determine the severity of rhinitis. We don't do that routinely. We should be doing for patients on immunotherapy to look at how they're doing in response, get something that's subjectively inputted, objectively outputted, so we can follow them over time. An example is the rhinitis control assessment test, the RCAT. Example, and it basically is looking about what symptoms and how frequent here, total score added up, and if your score is 21 or less, you talk to your health provider, you trend this over time. I'm not opposed if anybody wants to go down this pathway from a QI project. Then with that, the internal consistency in the test to retest reliability for RCAT is 0.77 and 0.78, so pretty decent. Its correlation between the RCAT and the TNSS, which is total nasal symptom score, just another, is 0.57, not so great. And then between the physician's global assessment, just another score is 0.34. We mentioned about the 21. Minimally important difference is 3 points. So, if you went from 21 to 18, that's a difference. That could be significant. It's fairly easy to do for a patient. They can go back quick. All right. Guidelines do number 4, do aeroallergen testing to confirm the diagnosis of allergic rhinitis in a patient with a history consistent with that. We'll talk more about that. And do not perform food allergy testing routinely. Yes, there's gustatory rhinitis, but that's more history diagnosis. A lot of people come in and I want the food panel to find out why my nose runs. That's not appropriate. Oops, sorry, missed that part here. Previous parameter did prefer skin testing over intradermal testing. Intradermal, you only do with hair allergens, you do not do with food. Current parameter gives equal weight to skin or blood test. It doesn't really, I'm sorry, I don't get that one, Jay. It doesn't care whether you're doing skin or blood test. It doesn't say a lot about the blood test, but I think they're equal. And in my practice, I'm fine with either, not both. And then they don't talk about how to interpret the allergy test. So if something is 0.36, which measures on our scales, it says positive and H by it here. What's that mean relative to the test being 99? I don't know. So food testing is often requested by patients. Don't do it. Okay. Allergy test, reasons to do a test. Whenever you're going to do a test, one of the questions is, what am I going to do with the information? Is it going to be helpful or confusing? One, it can make a diagnosis. Some parents want to know if they're allergic. Many referring providers specifically sent them in for allergy testing. I do think it's your job to assess whether it's important to do. I got to admit, I'm not very excited about allergy testing in a 9-month-old with a runny nose because the chance of sensitization is extremely low. It may help with environmental control. So if you don't need to avoid a cat and your test is negative, I will tell you if it's positive, the majority of people don't do anything different. So that's one of those times it doesn't change outcome. It may predict your seasonal patterns so they can plan accordingly. And then if you're going to want to go on allergy shots, that's certainly a consideration. You have to know what they're allergic to, know what to put in the extract. Okay. Jay's style always ask the parent patient what if they want testing here. And I think that's reasonable. You'll find some people, if you explain the situation, your 9-month-old runny nose and the allergen is not likely. I'm not saying no to testing, but with strong confidence, it's going to be negative, not change our management. Okay. Do remember, to become sensitized, it takes age. You are not, if you're 9 months old, you may not have even seen a tree season yet. You may have, because of pollinating in springtime. So you might not have had exposure after you've lived 3, 4, 5 years. Yes, you had many tree seasons, you might have had exposure then. If you're going to be sensitized to anything on the early side, it's going to be the things that are chronically in your environment. That's mites, pets, and potentially roach. And then if you had a blood test, something not uncommon, some come in with the results, but they heard they need skin testing. Their grandmother said, I had skin testing, that's what you need to get. And they come in with that idea. There's no reason to do it. You're spinning your wheels. They're relatively congruent on the positivity, negativity of the test. It doesn't usually change your management. Most of the younger kid too. This is about doing a test. If you're going to take a 4-year-old and you're going to put them on a nasal steroid and antihistamine anyway, does the test result change anything you're going to do? They weren't going to do allergy shots. It doesn't fit their life. You think they're too early. Your history's not overwhelming, or you think it's all allergy driven here. So that's kind of on the 0% side. Now, on the other side, if you got this kid who's totally atopic, they're an older child, they might have been tested years ago, they were positive, now they want to go on allergy shots, that's when you go to the right on the scale, because that's what you need to get them on shots. Skin or blood test, pros and cons here. Skin testing is here and now. Ideally, at the same visit, takes 20 to 30 minutes. The cons are a whole bunch of skin pricks on the back, which may be uncomfortable. To you and me, it should not be painful. So the kids will say, ow, it's burning. They may scream a little bit. It's the kind of warm sensation of an arterial lesion. Mosquito bite, basically, maybe a lot of them here. But to you and me, it's not painful. It's just uncomfortable. Antihistamines do interfere with it. And then if they have widespread skin disease or dermatographism, then you can't do it. It's really only semi-quantitative here. Many factors can affect the results, anywhere from the child moving around to the nurse placement, the skin prick test device itself, the extracts and how fresh, etc. The coefficients of variance is about 20 to 40% in the skin test. So you have some variability depending on who's doing it or when you do it. One consideration though is allergists get paid to do a skin test. If you go in private practice, you do a skin test, you get to submit the bill for each skin test and be paid for it. If you do blood testing, they go off the lab collects the money for doing the work here, then you get the work of interpreting, putting a letter or communicating to the family. You don't get paid for all that. That's kind of assumed to be in from the initial visit. You don't get additional pay. So it's very common that private practice where skin testing is done the most. And it's not a bad thing, it's a great thing. It's what's been around for 150 years or so. But just recognize that difference there too. If we go over to the in vitro or blood testing, ideally one stick and you're done. Antihistamines don't interfere with it. And if they have skin disorders, you can still get it done. You could maybe argue the time is more efficient for them to run to the lab and get it done. That's a little debatable depending on the lab. It does take 2 or 3 days to get your results back, and then you have to communicate that with the family here. It is very consistent. Coefficients of variance is about 5%. That's really small. So if you go run a dog and it says 7.4, the next time you run it, it's going to be 7.5. It's not going to be hugely different on that. Few things interfere with it, so there, and is more quantitative and can be converted to likelihood ratios and probabilities. And you'll find everybody's take on this is a little different. That's okay. Nasal dysfunction treatment, the allergic, you get environmental control, allergy shots, we do buff meds. Physiologic or symptomatic, that's the medication component, and then if it's an anatomic thing, surgery, just breaking the categories. This is again back to allergy practice parameters. You're going to see 4 of these are based on age and whether they have intermittent or persistent symptoms. These are by chance for 12 and up. And it all starts up there with a VAS or visual analog scale, just the happy faces, the sad faces, and then you just follow the algorithm, and the usual. You try this first, and then it wraps around to the next med if you're not having outcome versus exploring other causes. I don't expect you to be able to see and read all this here. And as we blow through the next few slides, it's mainly just know that there are a lot of variations on it. So there you go. And this is from the ARIO one, the European. So medications, antihistamines, you got oral, nasal, and ocular. First and second generation antihistamines, we prefer second usually. Decongestants here. You've got your phenylephrine, pseudoephedrine. Don't use those. The oral ones are not recommended for long-term use. I don't prescribe any of the D's on the end of these, like loratadine D or fexofenadine D. Oxymetazoline we'll talk about in a little minute here. Steroids, oral, nasal, ocular, leukotriene modifiers. Remember, montelukast is a common one we see. It's not an antihistamine. It doesn't interfere with skin testing. People come in all the time thinking it's that. Cromulins are rare these days, and anticholinergics are out there, can be used, like ipratropium, but we just don't see a lot of use with them. And then biologics. No FDA-approved biologics for the rhinitis, allergic rhinitis. Back to the guidelines, number 7, don't select oral leukotriene receptor antagonist montelukast for initial treatment. There's a box warning under a psychiatric events, kind of mood disorders, not antihistamines, we know that. For severe or intractable allergic rhinitis, consider short course of steroids here. Walk on that gingerly. It's not my first go-to. If somebody's horrible and miserable, they're going to the wedding, they're in the wedding, can't be all stuffed up, nothing's working, I've already double dosed everything else here, then that's a potential one we could use here. As Jay says, we use it for asthma. And then intranasal antihistamine as initial treatment for patients with the seasonal complaints. So somebody who needs quick relief, the intranasal steroid is probably be more helpful than a nasal steroid, which takes a little time to take effect. For monotherapy, for persistent allergic rhinitis, they recommend intranasal steroid first. Works best for the congestion, not as much for the runny nose here. For persistent nasal congestion, unresponsive to the intranasal steroid, you can go to a combo steroid antihistamine, or you can separate those. A lot of our insurance plans are not in favor of the combo products, so you usually just prescribe them separately, and a lot of this is over the counter. Jay promotes using oxymetabolisms for somebody with significant congestion not responding here. Initially, side of the bottle says 3 days. We've always said 5 days in our group here. There's some studies that say if you use it concurrently with a nasal steroid that you can use it longer for 6 weeks or so. You walk gingerly on that because I'm fearful if you give them that med, they may use it outside of what you recommended on here. And I'll show you a quick study on that. So first line is intranasal corticosteroid for non-allergic rhinitis, switch categories. And then intranasal antihistamine can also be used for non-allergic rhinitis. Not uncommon, we'll say, here's two of them, just try. Okay. So summary treatment of allergic rhinitis, non-allergic rhinitis. All right. If the symptoms mainly runny nose, your antihistamines, mainly those that have an anticholinergic effect, can be helpful. They've got nasal sprays, we've got orals. If it's primarily stuffy nose here, the steroids tend to work better. The oxymetazoline we referred to, and the oral decongestants, like previously said, not recommended. Too many side effects. This is a little on oxymetazoline, common name Afrin here, generics available. Intermittent or episodic use is reasonable. Colds is certainly reasonable. There's our 5-day mention there too. It's an alpha agonist, works fast, really quick, lasts up to 12 hours. Nasal steroids safe to use at the same time for up to 6 weeks. And you got to drop off the oxymetazoline. It is perfect for a cold because your cold's going to last a week with the miserable symptoms. Jay's figured is a no drip one. I don't know if that matters to me. The oral decongestant here for 4 hours, not really helpful. This is just one of the studies that looks at the use of placebo, steroid oxymetazoline, and then the combination of the steroid and oxy. And all said and done, the one on the right is the acoustic rhinometry or volume within the nose, and then on the right is the quality of life, and it all favors the double therapy. Just comparison between rhinitis and asthma. I actually like this for controller medicine for your rhinitis. It's the steroid. For asthma, it's a steroid. The quick reliever for rhinitis, it's a decongestant. For asthma, it'd be your bronchodilators. There's the combination products for both. For the runny nose, you're looking like kind of like anticholinergics, antihistamines, and all that. You can see that there's some overlap between the two diseases, so upper airway, lower. Do make sure you got the proper nasal technique below the nose to clear the mucus, shake the bottle. You might need to prime it if it hasn't been used in a while. Aim towards the back up to the lateral area. Gentle sniff. Don't be a big snort, and don't lie down right away or it's going to drain the back of the throat. Careful with epistaxis. Saline spray can help with that. Alcohol-free nasal sprays, there are multiple out there, can be helpful. A lot of the kids don't like the nasal sprays. I don't know how much is behavior versus the sensation. They do make these mist products. I list the brand names. They're both fluticasone products here, and that's just a nice little mist spray that's usually a bit better tolerated, but not usually covered by insurance. Some helpful hints to ophthalmic, refrigerate those here. That might be a little bit more soothing here. If you can't get those into the eye of a young child, you might have them lie down and just drop it in the needle, have a handful of fold, the blink and get some of it in there too. Careful on brand confusion. You guys know, and this, I don't like to use name brands in my talks, but I have to here. Zyrtec or cetirizine and Tab Chew Tab and liquid. They also make Zyrtec ophthalmic. But if you look at the two pictures, one of them is ketotifen, the other is levocarbastine, okay? So they use the brand name, but it's a different drug. And this happens with the Claritin/loratadine products too. So you're not, even they say, oh, I'm on Claritin eye drops, it's not Claritin, okay? It does say the name, but it's not the generic version of it. And then the other one, Patanol or Pataday Pazio, all three of those were prescription. They have different concentrations, 0.1, 0.2, and 0.7. The first one is twice daily, the others were daily. And anyway, arrow went away. They got rebranded when they went over the counter. So Patanol went to Pataday twice a day, Pataday went to Pataday once a day, and Pazio went to Pataday extra strength. Confusing the type of consumer. Back to our case presentation. So treatment, congestion was his main symptom. So put him on nasal steroid here. Scheduled use. It doesn't work great. Hit and miss on Monday, maybe Friday. We'll give him an oral antihistamine because he had occasional rhinorrhea. This worked within hours, so that would become PRN use. Testing, the family said, I want it, I got to know. So you went ahead and did it. We use, don't like terms panels, but we have a screening panel that's small, a number of arrow allergens instead of spending the big money. And he was elevated IgE to mice and dog. You talked about allergen avoidance techniques that are listed there. Mike casings remove stuffed toy animals from bed, wash sheets in the hot water, the furnace filter and lower humidity. And the dog, most of them aren't going to, remove the dog, rehome the dog. But you are just saying, well, maybe the dog out of the bedroom might help a little bit. See, don't know if it does. Conclusions: rhinitis or nasal dysfunction syndrome is a common condition that's out there. The allergy tests identify one type of potential trigger. Allergic can be treated with environmental control and shots. Most forms of rhinitis can be treated with medications. The drugs don't care if it's allergic versus non-allergic. For a runny, sneezy, itchy nose, use a nasal and or oral antihistamines because they work quick. For a stuffy nose, either use nasal steroid or more severe congestion, briefly use the oxymetazoline combination. And then for anatomic forms of dysfunction, they can require surgical intervention. Since all of your patients do get colds, some people will recommend a cold plan. In other words, how do you manage a cold when it comes on here? With a cold, the common medications would be like nasal saline to thin the secretions, suctioning to get the mucus out of the way. Oxymetazoline briefly for the nasal decongestion so they can sleep at night. And then some people will do an antihistamine that may dry them up a little bit at night. Some of them have a little anticholinergic effect, and that's a good deal too. Do remember that most infections work on ear and sinus and all. Most of them are viral and don't need an antibiotic. So there's some other helpful hints that, like if it's a double sickening, that may be more likely of a sinus infection that needs treatment here. Persistence of fevers, high fevers for days, kids who get sick are might jump higher and do antibiotics. But in general, most colds are viral. And a lot of parents, regardless of how many kids, need to be reminded, think it's viral, not likely to benefit from antibiotics. And then you have to have that conversation distinguishing a cold from allergies too. And most of the time, allergies are going to be more episodic and longer or seasonal here. The episodic may be, at dad's dog, but colds tend to be cycle.